Hello everyone and welcome to this webinar on the Romexis 6 Implant Guide Workflow by Zach Evans. My name is Saila Parmes and I work at Planmeca as a product manager for our Romexis 6 software, and I'm happy to be here with Zachary today to give this webinar over the Implant Guide Workflow. So during the next 40-45 minutes, Zach Evans will be presenting you the Implant Guide workflow, and after that we have saved some 10 to 15 minutes to answer any questions that you might have. So please, at any moment of the webinar, feel free to type your questions to the questions section. You can add your questions there, whatever they are related to Romexis. And I will be maybe answering some of them already by writing during the webinar, but some questions we might save till the end so that you will be answered by Zach directly, and you will all hear the answers to those. So any questions that you come up with, type them please to the questions section. And apart from that, I just want to welcome Zach Evans, DMD, PhD periodontist from the Medical University of South Carolina. He works there as an assistant professor, and Dr. Evans has been lecturing all over the world during these last years, and we are very happy to have him now here to present you the Implant Guide workflow. So please, Zach, whenever you're ready, you can please share your webcam and present yourself.
Okay, thanks. Can you hear me, Saila?
Yes, we can hear you. For now, we cannot yet see you.
Okay, hang on. I'm trying to. There we go. Let's see. Yeah, let me hop on the webcam real quick. Good morning. Hi, all of you. It's really nice to see you and be with you this morning. You know, I'm definitely getting more used to doing things online, so it's my pleasure to be with all of you this morning. I really appreciate the opportunity. Thank you, Saila, for the invitation. Greetings from Charleston, South Carolina. It's morning here, but I know a lot of you are a little further along in the day, all scattered all around the world. So again, it's my pleasure to be sharing some of our experience using Romexis 6 for Implant Guide workflow. We've been using it for a while. We were really fortunate here at MUSC, and I'll kind of mention it again. We have a really nice partnership with Planmeca, and we do a lot of beta testing, and we do some consultation for product development with them. So we've been using some early versions of Romexis 6 for, oh gosh, I guess a little over a year. And I'd like to share our experience using that, but also give you hopefully some guidance on things that we've done to be more successful doing guided implant surgery with myself and my practice, but also when I'm teaching students and residents, and definitely learned a lot from there. So again, thanks a lot for hanging out this morning, and let's do it. All right. Saila, can you see the presentation screen?
Yes, yes.
Okay.
And I think
Perfect.
you can close your webcam now, so we will see your screen even in bigger.
Ah, got it. Let me turn that off. Is that better? Yeah?
Yes, perfect.
Okay. All right, guys. Thanks. Okay, well, here we go. Thanks again. So just a quick disclosure. I am on faculty full-time at MUSC. I've been on faculty full-time for a little over 2 years now, and it's been a really incredible opportunity. We're really proud of the programs that we've developed here, from dental education, resident education, but also the advancement of digital dentistry. So I'm really lucky to be part of this team. And then also disclosure, I do some consultation and some speaking for Planmeca, which should be no surprise. This is our dental school. I'm actually sitting right behind this picture in a building right behind it, but these are our new dental clinics. We're really lucky here to have an incredible facility, but more important than that, we have an incredible faculty, and we have a team of dedicated, young, really ambitious individuals who are motivated to create advancements in digital dentistry. So again, it's really an honor for me to be able to share some of that experience with you guys. We are really lucky. This is an effort headed up mainly by our colleague Wally Renee, whom a lot of you probably know or know of. He has created a residency program in digital dentistry, and we actually have our first 2 residents joining us in June this year. So this is a brand new program. We're really excited about this. It'll be headed up by Wally Renee and then another one of our colleagues, Mark Ludlow. So we're really fortunate and lucky to be in this environment. Let's talk a little bit today about digital solutions for guided implant surgery. I'm gonna kind of create 2 themes. One is I'd love to just kind of walk through what we're using as a typical guided implant workflow and solution, a formula, if you will, that we've created that seems to be working really well for myself, mainly in private practice, but also from the perspective of teaching our residents and our students. And the focal point for that is definitely the software that allows this to happen. And again, we're really fortunate to have had the ability to use Romexis. We have a lot, if not all of the major software systems available to us at MUSC for guided implant planning. And a lot of them have their strengths and weaknesses. But I can't think of a better testament than this for Romexis, which is our perio residents who I spend the most time with. They really have their choice of the major implant planning software systems. And I find that they gravitate towards Romexis when they're planning their cases on a day-to-day basis. And there's some reasons for that, and I'll kind of share those. But I can't think of a better testimonial than that people who are given the freedom to choose tend to use this one because not only is it powerful, but it's also very, very elegant and very easy to use. So we'll definitely discuss that more. I like starting my implant talks with a couple pictures. Some of you who I've lectured with before or done courses with, I think a lot of you enjoy some of these photos, but let's think about the question of why we're here in the first place. And I think this is a good example. This is a case that was restored at MUSC with really severely poorly placed implants, right? So here are the impression copings. You don't have to have a lot of dental or implant experience to understand that especially the most anterior implant is severely malpositioned, and it's questionable whether or not it's even restorable. So how does this happen? It's 2 reasons. Reason number 1 is poor execution, right? So from a technical perspective of implant placement, it's poor execution, whether you intended the implant to be there or not. The other part of the equation, though, is poor planning. In other words, even if you have really good hands and you're really good at placing freehand implants, how did you come up with the idea of where that implant position should be? So when I see something like this, I think of 2 failures. One is obviously the surgical placement, but number 2 is how did you develop an idea of where the implant should go in the first place? Was it you just kind of looked and guessed, which when we're doing freehand implants is essentially what we're doing, or let's say you did it guided and you still had a malposition, then how did you come up with that guided implant position in the first place, right? Here's another example, and I love this example. This is a case restored by the student clinic at MUSC. This case was done by one of the residents here at MUSC. The bridge on the left side, the implants were placed freehand. The bridge on the right side of your screen, so the patient's left, was done with guided implant surgery. And I think, same patient, different sides of the mouth, totally different philosophy on how implants should be done. And, you know, I think a lot of us who have a lot of experience doing freehand implants would argue that we would not end up with a result that we see on our screen left. However, would we necessarily end up with a result as good as what you see on the right? And the answer is maybe, maybe not. So how do we get to that result that we're seeing on the right-hand side? Let's talk about the entire workflow. And I'm going to talk about the software strategy and solution that we use to bring it all together. From a technical perspective, from a surgical perspective, we have a lot of options right now, which is really, really kind of an amazing time, obviously, to be in dentistry and implant surgery. We have the whole spectrum of skills that we can use in order to place dental implants. We have the ability, and I learned how to place implants freehand. We can do pilot guides. We can do fully guided implant surgery, which could be with a static surgical guide. It could be with a new dynamic navigation system. So we have so many options, but I think in general, we could all agree, and the literature is unanimous on this, that from an accuracy perspective, from any parameter that you can imagine measuring, whether it's implant position, bodily, angulation, depth, that fully guided implant surgery on average is going to be more accurate compared to a planned starting point than either pilot guided surgery where you're just doing the first drill, maybe two guided and then the remainder freehand, or definitely more so than freehand. So let's just go along this track. Let's follow the track of how can we create plans and execute fully guided cases most successfully. We're doing a really, really interesting study here at MUSC, and shout out to our graduating perio resident, Maggie Jones, who worked with us on this project. But what we've looked at is using different digital strategies to plan implants. Is there a difference potentially in implant position and placement? So I'll explain what I mean. If you look at some of the large meta-analysis, if you kind of average the deviation between freehand and guided surgery, again on average, it's somewhere in the neighborhood of about 3.5 to 4 degrees of error. If we look at digital strategies, and this is from our study, if you look at what we call an automatic tooth, so imagine the tooth that you could use directly in the CT to plan prosthetically. In other words, it's from a library of teeth that you can just drop into position without reference to occlusion or maybe gingival aesthetics, compared to implant position that we would look at based on a full diagnostic wax up. And it's from our study, we're seeing this is based solely on the digital plan. This is not based on the implant placement, approaching 5 degrees. If we look at using an intraoral scan only, in other words, no diagnostic prosthetic wax up, we're approaching, again, 5 degrees. And we exceed 5 degrees if you're planning an implant on the CT scan only if you compare it to an implant planned on the wax up. So what do I mean by this? Here's an example. So here's a CT scan. These are the parameters we use for our study. Parameter number 2 is using an intraoral scan. 3 is using the library of teeth that you can find within software systems. And 4 would be a full diagnostic wax up. And I'll describe in detail the process to make a full diagnostic digital wax up happen. So we looked at those. And if you look at a lot of practitioners with a lot of digital planning experience, just planning digital implants based on those 4 parameters, look at the scatter, the deviation in possible implant position. So that's all of the implants. And there you can likewise see the implants under the surface. These are the implants that were placed with the CT scan only. These were the implants planned with the intraoral scan only. We're getting better when we look at it with the automatic teeth, or the dummy teeth that we like to call them, that you can just drop in from the 3-dimensional library. But if you have a full diagnostic wax up, you can see the difference in deviation here. So not only am I an advocate for guided implant surgery, but I'm also a strong advocate for using an implant workflow, a digital implant workflow that includes a full diagnostic wax up. And there are some caveats to this that I'll mention. as we're going. So for a bridge case like this, where you have a lone posterior extension tooth, in other words, you're waxing up a tooth that has no adjacent teeth, then it's going to be highly prone to error. And in fact, here are the data if we're looking at standalone teeth. And we're far exceeding the error that you would get comparing freehand to guided surgery. So, 5, 6, 7, almost up to 8 degrees of at least angulation deviation for standalone teeth. So I think in cases like that, it's almost critical that you have a full diagnostic wax up. How about for a single unit tooth? Well, Maggie found that in general, you can actually use an automatic tooth from a library. They work pretty good. Here is the exception. In the anterior, the maxillary anterior, a single unit implant tooth. So let's say it's tooth number 8, tooth number 11. We find that the angulation and bodily position are not significantly different. However, depth is. So even with an automatic tooth, we're still having trouble planning depth, platform depth, when we're using an automatic tooth compared to a full diagnostic wax up. So I'll go, again, in detail and show you the process that we've come up with that we teach to get the most likelihood of success for guided implants. And this is kind of the formula, right? So having a prosthetically driven plan with fully guided implant execution, to me, is the formula for implant success. Now, what are the tools that we need to make that happen? We need an intraoral scan or a digital model inside the mouth of the hard tissues and the ridge, right? So when we're planning implants. We for sure, most critically, we need a 3-dimensional CBCT of the patient. And those are the essential components for the planning process. However, if you want to continue the digital workflow beyond that, you can absolutely 3D print the surgical guide, and indeed we do on a daily basis. And then the final step, if it's part of your practice, is using CAD/CAM technology in order to execute the restoration. So all of those things together, we've had really great success. But from the planning perspective, let's go through that process. So when I think about restorative design, when I'm planning an implant, this is critical. And what are the components that are important? Well, if we think about what a future restoration should look like, if we break down the components, especially in the maxillary anterior, an aesthetic case, those important components are gingival and restorative margin. Absolutely very, very important to have an idea of where that is. And that can be very difficult to guess for us, whether we're doing freehand implant placement or even if you don't have a really good diagnostic wax up. It can be hard to visualize exactly where that should be, so critical. We need to know the prosthetic emergence, the overall emergence profile of that tooth to help guide implant position. And then obviously the incisal or occlusal position. We need to know what the occlusion looks like. So all of those things balanced together gives us the guideline for us to most accurately plan implant position. So having, to me, a full diagnostic wax up is very important, and I'll show you the workflow for that. But once we have that, we have to balance that with the anatomy, right? So what do we see on the CT scan? So this would be a difficult case to plan that we did. It's adjacent to an implant. The bridge is not really that significant. We may have to do a little augmentation or spreading. But this is difficult to do clinically freehand, a case like this, in an anterior, aesthetically demanding case. So having an idea not only of where the future prosthesis can go for implant emergence, but obviously having the CT scan for the data of adjacent anatomy and critical components. To balance all those things together is the most important thing we can do when we're planning these implants. So having sufficient distances from the gingival margin to the platform position, so minimum 3 millimeters in the anterior. If we can get a couple millimeters at least of labial plate thickness for an anterior case, we'll do that. So thinking about all those things in harmony is important when we're planning these cases. And one thing I really like to do, which I'll show you, is I like to get just a 3-dimensional perspective as I'm planning these cases of, based on the implant position, what does the emergence profile look like, right? And I find as a periodontist that when I'm communicating with my referring dentists, that being able to send them images like this so that they have a really good idea of restorative prognosis really makes the communication process much, much more valuable. So, being able to share these images is very easy, and I love doing that. But I like seeing them in real time while I'm planning the cases, and I'll be able to share that process with you. Okay, so step 3, what do we do after we plan, do a digital wax up? We plan the implant. Well, we can 3D print a surgical guide, which is my preferred method of doing guided surgery. I like to print my own guides and use those compared to some of the dynamic navigation systems or having someone else plan and manufacture the guide for me. So step 3, doing the guided implant surgery, and then moving on to the restoration phase after integration, or whether you're going to temporize the implant. So that's our digital workflow. Let's talk about digital restorative design. So I'm going to kind of go on a tangent, especially for a periodontist here, and talk solely about how we create these digital wax-ups. I have a really efficient process for this, and I'm going to share it. So this is, for those of you who are doing CAD/CAM dentistry, this will look very familiar. We are using the CAD/CAM components of the software in order to generate restorative designs for implant planning. So I'm using all of these CAD/CAM tools. And by the way, if I can do it as a periodontist, you can do it, no doubt about it, having learned this. So this is PlanCAD Easy within the Romexis software. And what I normally do is select the tooth site of interest, and I design it as if we were going to do a CAD/CAM crown. Once we do that, I'm going to get intraoral scans of the arch of interest. So in this case, we're looking at implant site number 8 or 1-1. And we also need the intraoral scan of at least the opposing segment, if you will, enough data that we can see the occlusion. And then beyond that, we have to get a bite registration, an intraoral scan of the bite registration. Now, if you don't have this technology in your office, you could potentially take stone models and digitize those. But obviously, as part of a digital workflow, having an intraoral scanner is really, really beneficial. This is the intraoral scan, but also with the upper and lower models merged. So everything's merged together. That's why it looks funny. We have a pre-op tab, and I'm going to explain that a little more. So we're going to take our upper intraoral scan, and we're going to copy that into the software's pre-op tab. That allows us to use a really clever feature that I'll show you in a minute to help with the diagnostic wax-up. So, but for now, we have the bite registration with the upper and lower intraoral scans, and we're ready to proceed. So this is maybe one of the most critical steps when we're planning a restorative design for implant plan, right? Which is we're going to be able to create an idea of where that gingival margin is going to be. So in this case, the first step is to define the orientation of your site. This allows us to use some tools within the CAD/CAM planning process. And once we define that orientation, we're going to trace a margin. So when you're planning these cases, it's important to think about where the emergence of that implant abutment restoration is going to come through the gingival tissues in the future. Why? Number one, because it's going to help us create a more accurate prosthetic design, but also it's going to allow us to define where that critical landmark is in space. We need to know where that gingival margin is, because that is the parameter we use to decide implant platform depth in the maxillary anterior especially. So it's really important to have a very good idea of where that exists. Once we have the margin, the software is going to propose a tooth size and shape for us, and we can easily manipulate that until we get a rough idea of tooth position and dimension. We're going to rotate and move and resize this tooth in order to give the software, like I said, a starting point in order to design a possible restoration for this site. So we're just going to tweak the little position and movement and rotation of this. Once we're happy with that, we can move on to the design phase. So the first step. And for those of you who do CAD/CAM dentistry, this is second nature. You take that restorative plan and you apply it. And what it's doing is it's merging that plan with the margin that you've created. So this may or may not be exactly appropriate for your site. And you can see that in this case, we definitely had some drop out of the papilla at the midline, but especially between the lateral incisor and the central incisor. So, you know, we definitely have some possible under contour here. Not super excited about the incisal edge, so we're going to manipulate that using the rubber tooth tool. And we can sculpt this tooth in order to look a little more diagnostic for the site. Now, how much time do I spend on this? This entire process, I try to keep less than 5 minutes. For a case like this, you could spend a couple more minutes designing this restoration, especially if you're going to use that design to create a temporary restoration to go on your implant, which indeed we did in this case. But for the sake of implant planning, you don't need secondary aesthetic anatomy on your wax up. It's just not necessary. What do we need? We need the incisal position, we need the gingival margin, and we need an overall idea of what the occlusion and emergence profile is going to look like. This case is interesting. It's kind of a class 2 case here. So the occlusion is very deep. It's a deep bite, but we have some freedom in terms of palatal clearance. So in cross-sectional view, I'll manipulate the occlusion, and we'll do our final checks and make sure that we're happy with the restoration. So if I were just using this wax up from an implant planning perspective, I would have been done already, and I would have moved on. So, you know, from there we can exit, and the computer will be able to save that information, and you can import it in directly into your implant planning process, which we'll show you in the next step. But before I do, let me show you a really clever tool that I use all the time in order to create these wax ups more efficiently. So let's go back to the step where we've scanned and we have our gingival margin defined. Remember I said that we can take our intraoral scan of the upper arch and we can create a copy of that, and we call that the pre-op scan. So from that, what we can do, and what we're taking advantage of some tools that obviously the CAD/CAM dentists use all the time. I'm going to select tooth number 9 or 2-1, and I'm going to trace around it all the way. And what we're going to do is, by clicking a button, we're going to be able to create a mirror image clone of this tooth. So we've selected it, and then we're going to move on, and you can see instantly we have a mirror image perfect copy of that tooth. All I have to do is just fine-tune the position of it at this point. So this is a tool I use even if I'm planning maybe even an easy single unit premolar case. It's just so quick and efficient, and you get a perfect result. And a lot of times it can be hard to get the right proportions, especially tooth size, position. So using this tool is very, very beneficial. And you can see right away we have a perfect replica. We'll take that to the design tab. That's going to merge that replica with the gingival margin that we've defined. And again, because we have some drop out of the papilla, there will be a little bit of visible asymmetry here. It will look a little under contoured. Now, when we did this case clinically, we left it under contoured so that, you know, when we placed the temporary restoration, we had the hope that some gingival tissue would collapse into the space. But with a little manipulation, we can change the contour of this, and we can make it look just about perfect. I'm taking my time on these videos. These videos, by the way, are done in real time. They're not sped up. So this is a periodontist using CAD/CAM technology. Again, a lot of you listening can probably do this a lot more quickly and a lot more successfully than I can. But checking all of those things that we like to look at, occlusion, and you know, using the tools within the software to be able to manipulate this until we're happy. Maybe the incisal edge position is not perfectly symmetrical, so we can take advantage of some of the tools here and just drop that incisal edge position down, and there we go. So within the span of 2 minutes, we have a really good wax up. Now, from an implant planning perspective, this would be absolutely perfect. This would be ideal. We might do a little more work on it if we were going to use this also for restorative turnover. In other words, using this digital design to make a temporary restoration. So we've got our digital plan. Let's move on to the implant planning and surgical guide planning process. First things first, we're going to capture our CBCT. And we've been using the Planmeca CT scanners for years. We have a Promax Mid now that we absolutely love. We're getting exceptional quality images, but it's really nice just to have technology all within one platform. I usually skip through what we would consider the traditional anatomical views when I'm looking at a CT scan for implant planning. I will usually jump right into the implant planning tab. Step number one is to select the arch of interest, the one we're going to be doing the implant on, and create a panoramic curve so that on that bottom left panel of images, we're getting that perfect cross-sectional panoramic curve slice view so we can look at the site of interest. That's usually step number one. And then after that, we're going to go ahead and we're going to bring in those models, the intraoral scan first of the arch that we're working on. Obviously, this is important not only to plan the implant, but so that we can also make the surgical guide, because this will be the digital surface upon which the surgical guide is manufactured. So how do we do this? If you farm out your surgical guides, someone is doing this for you. The more experience I have doing this, the more I don't know that I would trust someone to do it for me. This is one of those really critical steps that has to be done perfectly. Merging these scans together, if there's any error in this process, it will translate into error during the surgical phase. So how do we do it? The software really needs 3 points of common data. So basically just selecting points in space that are equivalent between the intraoral scan and the CT scan. Now, what are those points? They're going to be teeth or restorative surfaces, right? So you're trying to find, spread out, common data points to allow the computer to fit these things together. So once we have that, the computer is going to run an algorithm to do a best fit analysis and fine-tune the fit of the intraoral scan to the CT scan. So once we have that, and by the way, green is good. If you see green all the way across, I'm confident to use that merge moving forward. So we have our intraoral scan. The final thing we need to do is bring in the wax up. Within this same software system, within this, the patient's same file, the process is really easy. All you have to do is go through and import that in, but instead of having to physically merge it, it's going to use the positional data from your wax up. So it uses the existing match, and boom, there we go. We have our full diagnostic wax up now in position, merged perfectly with our CT scan. And obviously this is what we need to be able to successfully plan our implant and create the surgical guide. From here, it's time to plan an implant. Planmeca, in this software system, they're updating the implant library almost on a daily basis. I find that if anyone ever contacts me and says, gosh, my implant system is not in the library, if we forward that information on to Planmeca, they're immediately on it. I think they have about 100 different systems now in their library, so it's very comprehensive. Once you find the implant system that you're comfortable with, then we are at a point where it's time to go ahead and plan it. And this is how I set up all of my plans. On the left side, I put the view and implant-centric view, meaning we have cross-sections using the implant itself as the long axis for the radiographs. So this is absolutely essential, in my opinion, to have it in that view. A lot of things that you can see on a cross-sectional view or a traditional two-dimensional view, you're kind of missing out. So implant-centric view obviously is very important. This is a really difficult planning case. The bone quality isn't spectacular. We're probably going to need to do some additional augmentation at the time of placement or ridge spreading, so we really want to be careful in this case. But I want you to look, as we're moving the implant position, if you look at the volumetric view on the bottom right side, you can see in real time how the implant position change translates into a restorative emergence change. This 3-panel view is how I pretty much plan all of my implants. I absolutely love having it set up like this, and I found that it's been really, really helpful to be able to see a lot of information at the same time so that we can plan quickly but also really accurately, right? We can take some measurements here. One rookie mistake that I find that our residents do all the time is there's this tendency to place the implant platform at the crest of the bone. But in this case, we're 2 millimeters away from where the future gingival margin is going to be. Absolutely not adequate in the anterior. We need to go ahead and drop that implant a little bit, right? So, and we can remeasure it to make sure that we're happy about the depth. So slightly subcrestal. That is where having an idea of where that gingival margin truly needs to exist is critical. With a a stock tooth library tooth, we may miss out on that landmark, and therefore you may not get the perfect implant depth. So once we have our implant position and we're happy with it, the way I do the workflow is I add the guide sleeve later after I plan the implant. Once the guide sleeve is in position, you either manually enter the drill length, or if the drill lengths are set based on the drill kit, the manufacturer has released that to Planmeca, then you can toggle up and down the sleeve position and it will automatically translate into the right drill length to be used. So super easy, similar to other systems, but it makes it really easy. And in this case, you can see our sleeve is impinging on the incisive papilla. So we may have trouble getting the guide to seat if we were doing that sleeve position. So we're going to go to the next length in terms of drill length and make that work. So everything looks great. One thing that I didn't mention while I was doing it is you can rotate these sleeves around. So for systems that allow you to include implant timing, you can define the implant sleeve rotational position. It's very easy to do, and you can incorporate that into your plan. We're ready to roll and make our surgical guide at this point. So here we go. We have everything combined. We have implant position. We have our guide sleeve in position. We have our intraoral scan all merged with our CT scan. And I think you could see, again, this is in real time, how quick and efficient this is. Moving on, the surgical guide module is directly built in. And it just goes step by step. Step number one is usually something that I'll redefine, which is setting the path of insertion for your surgical guide. Once you have that ready, then you're going to select the area of the teeth and soft tissues that you want covered by your surgical guide. So we highlight that, and we allow the computer to go ahead and render a design for the surgical guide. You can manipulate the thickness of this material, but at this point, all we have to do is trim it back. I like the kind of almost organic way that this software works compared to some other software systems that we've used, where it can be difficult to get exactly where you want those margins to be. So if I'm planning a surgery and it's going to be flapped or flapless, I really want control over where these flanges may exist. Do I want the flange to reflect the flap? Do I want it out of the way so that I can irrigate, etc.? So I really like this kind of free-form way that they've designed it. We're going to get rid of the flash here and get it ready for 3D printing. But you can see the overall shape of this coming together. The guide sleeve housing is in position. And there are a couple more things that I like to do after I get rid of all of that excess flange material. You can customize these any way you want. And the more you do of these, the more you'll get a feeling for how far does the guide need to extend for stability. I would say at least a few teeth, anterior, posterior, mesial, distal. I like to get rid of the material under the guide sleeve holder so that we can maybe improve the ability to do irrigation if we would wish. You can see when I erase, it can go all the way through your material. You want to make sure you're not getting rid of any of the actual sleeve holder material when you're doing this. It's one rookie mistake that I make all the time. Trimming this until we're happy. Again, I like my guides to extend to both sides of the arch for stability, but also I find that having a little more extension of the guide allows myself and my assistant to stabilize it and place it more easily. So having that, placing windows through the guide to confirm seating when we're using it clinically. And we're pretty much done. If you have a multiple edentulous case, sometimes the material can be thin between the edentulous sites, so you could even add a bar for support. It's very easy. Click the origin and termination for those two sites, and you can add a bar for support, and we're done. We're going to export this. As we export the surgical guide, it gives us a true STL. So we're not locked into a Romexis system. These are universal digital file types. So we have an STL image that can talk to your 3D printer so that we can 3D print our surgical guide. And again, we have everything merged together. Our plan is pretty much complete. We're going to 3D print that surgical guide, and we're going to go ahead and use it surgically. We're going to insert the sleeve and then proceed with our surgery. So I think you could see how quick and efficient this is. From a time investment perspective, for those of you who are not doing this yet in your practice, there are a lot of considerations to think about in terms of investment, obviously of money, but also of time. And I think one of the big roadblocks for a lot of practitioners is it worth my investment of time, number one, to learn this process, but number two, on a day-to-day basis to sit down and plan these cases. I am not the world's best digital dentist. I think I work with the world's best digital dentist, and his name's Wally. But, if I can do it, anyone can really do it. I spend, on average, a total of about 15 minutes planning an implant case. If I think about that from a time cost perspective, if I send a case out for a surgical guide, I'm paying enough that I feel like it justifies my time to plan these cases, to do the wax up and to plan the case and print my own guide. However, I've found that I'm doing essentially all of my implant cases guided, even ones that I would consider to be easy freehand single unit sites. Think about, upper second premolar case with lots of bone, right? Easy to freehand. The reason that I'm doing it is, number one, I just feel more comfortable now knowing that the outcome is going to be perfect from an implant position, but also a restorative perspective. But number two, I found that it reduces chair time significantly. I'm not having to kind of go back and check my position. I'm really just doing the case and not exaggerating. A single unit, easy, flapless case, you're executing in 5 minutes. To the point where I'm doing a lot of these under local, where I used to have sedated these cases. So lots of advantages, I think, for you to adopt a workflow like this. So within their software system, they tie a lot of this technology together now in Romexis 6, which is nice. In this new era of digital dentistry, I really hate having to use multiple software systems and having all these files kind of scattered around, saved on my desktop, saved in software systems, whatever it is. So Planmeca has sort of thought ahead, and within the patient's file now, it's a comprehensive digital repository of not only their radiographs and their patient data, but also all of this three-dimensional data as well. So it's really nice and convenient to have that all within one place. And I find that very, very useful and probably one of the major strengths of this system. How about an immediate implant? Let's look at that real quick. That is actually a pretty easy process. So here's a case that I've set up, this premolar case. Let's say that we're doing this immediate. We can trim, if we would like, our volumetric view to be able to get a really nice, clear view of the three-dimensional radiographic data, but also be able to look down on the emergence. But also being able to see very clearly the implant position. Once we have this, and once I'm happy with the implant emergence, just like the case we looked at before, then we can move forward with the implant guide design. And the way that works is very efficient. Really, all we have to do is jump right back into that implant guide module, and we can use a feature that they've included now to be able to erase the tooth. Before, how did we do immediates? Well, you know, back in the Stone Age, literally, we would digitize a stone model where we've manually cut off the tooth from the model so that we could create a surgical guide, right? And here we go. We're going to add our sleeve. We're going to set our drill length. But now, and then after that, after we stop doing that, we would take these STL images of the intraoral scan and we would move those into maybe a third-party software system and digitally erase the tooth, right? Melt the tooth away. Using Mesh Mixer and things like that a lot for that process. We don't have to do that anymore. So when I'm doing immediate implants, if I have the luxury of planning ahead, it's very easy. I've even done some cases where a patient has come in symptomatic, and I'll plan the case as long as they're willing to wait a little while. I'll plan the case, get them numb, and quickly 3D print a surgical guide, especially for a high stakes like anterior case where I'm concerned about implant position, where placing an immediate may be difficult. So it's definitely possible to do that. So we're going to move forward and we're going to plan our surgical guide using the guide module again. And like I said, all we have to do in this case is go ahead and select the tooth using their tooth removal tool that they have now in their guide module. So this is a relatively new feature that they have, which is very welcome, and it's really an elegant solution. All you have to do is select your area where you want your surgical guide to cover, and then select the tooth to be extracted, and it will give you a surgical guide with the sleeve holder in the proper position. Important point for those of you who are using the software or are planning to adopt it, you want to be really careful here and not invade the adjacent tooth spaces, right? So why? Because if you do, it will erase that area as well. So be careful at your contacts, because if you do, then you'll create a surgical guide that's not going to be able to seat. So don't invade your contact points. When in doubt, stay within the contact a little bit. You don't necessarily have to eliminate the entire contact of the tooth you're digitally extracting, especially if your sleeve doesn't really extend all the way to the contact point when you do this. So here we go. We are going to tell the computer to go ahead and create a proposal, and then we'll erase that and customize it so that we're happy with it. And once we do, then we'll just process the guide just like we did on the other case. So there you go. It's eliminating that tooth, and it's embedding the surgical guide directly into the space, and I'll skip the rest of this. Let's talk about one final way that we're planning cases. This is what we would do for a full arch case. We're doing the dual scan, and the Romexis CBCT scanners have a model scan setting, so you can take a CT scan of the denture itself with radiographic markers. In other words, take it out of the mouth, put radiographic markers on it, put it on your CT scanner, and take a model scan. Put the denture back in the patient's mouth, take a scan, and now you have everything you need to do full arch planning. So here's a case we did that we created a surgical guide and made a restoration. In fact, we 3D printed the temp restoration just based on that STL model of the denture itself. Let me quickly show you this workflow. So what do we have? We have two CT scans. And Sila, sorry, I think I'm taking a little bit longer. I'll probably run over a minute or two, but there are a couple of things I do want to share. This is the CT scan rendering of the denture itself. And you can see these model scans are exquisite. So the days of having to denture duplicate with alginate and things like that are over for sure. Using the denture itself and taking a scan is fantastic. You could even use this to create a custom impression tray. You know, you could 3D print that. You could even cut the teeth off and use it as a a possible tri-indenture with wax rims. I mean, you can get really creative with this technology because now we have a three-dimensional model of this. But what we're going to use it for is we're going to import this into the patient's CT scan, right, using these common radiographic marker points. And by the way, you can buy radiographic markers from vendors, and those can work pretty good. I found that some of the glass beads that we're getting throw off a little bit of scatter. Here's what we use. We use expired composite. So if you have any laying around your office, just go ahead and make some 3mm little roll-ups and cure them and sticky wax those onto the denture, and they work fantastic, we've found. So we're going to merge these together. We're going to merge our three-dimensional model of the denture with the CT scan using these common radiographic marker points. And it's the same process we used when we were merging the intraoral scan to the teeth, which is select some common points. And the more you do of these, it looks like a whole constellation of beads here. You'll get better about finding your point in space as you get a little bit of practice. But you're going to use 3 of these, and you're going to merge them together. And at that point, it's going to automatically bring it in. Now, when I'm truly planning a case like this, I create a point at each of the markers. And I recommend 4 to 5 markers on the buccal and 3 on the palatal surface, okay? So number one, that gives you a little redundancy if one falls off while they're wearing it, but more so, the more points, the better in terms of accuracy. But you can see the computer did a great job of merging that together. We now have a perfect merge of our denture with the with the CT scan. We can plan our implants, we can add our sleeves, and we can jump into the guide module. And like we have a tooth removal feature, we also have this denture feature, which essentially what it's doing is it's taking the intaglio surface of the STL image of the denture, and it's embedding that or creating an inverse image of that. So click of a button, now we have an inverse of the intaglio surface. And you can tell the computer to go ahead and create the surgical guide. We can trim that just like we did our other guides. And then we very quickly, we have a surgical guide that we can use for full arch cases. Now, in a case like this, I would probably also add guide pens, which are also in the implant library for guide stabilization and fixation. So here you go. This process using the dual scans allows us to create surgical guides for full arch cases. It's quick, it's efficient, it's easy, and we've had really good success with this. One final note for the software, as you're getting started using it, they've also added this really clever feature. When our residents are learning how to do this, they either pester me and have me sit down with them and show them, or I have to create updated manuals that they print and look at while they're planning their cases just so they can follow. They don't have to do that now. There's a workflow wizard within the software, and it goes step by step for the implant planning process. And it has hot links in this process, as well as embedded video walkthroughs. So you can kind of follow step by step with the software, and it will walk you through the process, which is really, really nice. It can be intimidating to jump into a new software system, but they make it easy. Let's look at a case, and then we'll be all set. Again, I know I'm running a couple seconds over. Here's a case where we've brought everything together. Really difficult case from aesthetics and function. And, you know, the most important thing is having a vision of what the future is going to look like. And how do we do that? The same way we did when I was creating the wax-ups for these single unit teeth. However, in these cases, we're using one more feature within the software, which is digital smile design. So this is kind of a screen capture of a different case. But the smile design allows you to really beautifully create ideas based on facial aesthetics of what the future gingival margin and teeth could look like. We also get this wireframe positional and dimensional information of the teeth. You can export this wireframe and bring it right into your CAD/CAM design. So if you're creating an aesthetic workup, you can translate that into your digital wax up. And it's a really efficient, clever process. So that's how we tackle these big, large difficult aesthetic cases. Plan the implants just like we did, make our surgical guide, and execute the surgery. So this is kind of where we started, and this is a 3D printed temporary restoration that Wally and Tony made that I work with. They've been having some incredible results with 3D printing of temps, all based off these simple digital workflows that we've talked about. And by the way, this patient has not been able to afford his final prosthesis. He's been wearing 3D printed temps for, I think, over a year at this point. So they can work very well. There are a lot of naysayers who challenge us on that. On a day-to-day basis, this is really what I'm doing. I'm doing single units, right? They get referred to me. And if you look at on the right side panel of each of these images for these implants, you can see the digital design. And I'm going to overlay on the post-operative periapical radiographs. You can see those merge in. They're perfect. And this is what I get on a day-to-day basis using this workflow, especially using the new software system, that I'm able to accomplish these really predictable results just about every time. The technology, the hardware that we use is incredible from Planmeca, but the software is obviously what ties everything together. The software at this point in the digital dentistry world is the critical component, and I think that's the magic behind what Planmeca has accomplished at this point. So thank you. Sorry for running over. Please go ahead and take my contact info. If you're interested in messaging me, feel free. If there's anything I can do for you, I'd be happy to help you. And I really appreciate you guys being with me this morning. It's been fun. And Sila, you want to shall we take questions? If anyone wants to stick around for a second. So, yeah, I've got a few minutes. Yeah.
Yeah. We have 3 minutes left, so let's be quick. But thank you, Zach, very much for the interesting and very complete presentation. I selected a few questions. I answered most of them already by typing, but there are a few questions that I will now ask so that everybody can hear the answer. So this is for you, Zach. How do you go about dealing with scatter from other restorations when you are merging your files?
Okay, so two critical points to that. Number one, patients with an extensive restorative history are going to have scatter no matter what. Think about, full arch bridges and things like that. It's going to happen. So 2 ways to combat that. Number one, if I'm taking a CT scan to plan implants on a patient that has teeth, I'm using the word always here, and I'm reluctant to use the word always, but I pretty much always open the bite when I take the CT scan. Why? Because what I find is, even though we have scatter, and if you remember that first case I showed, a lot of times you can get pinpoint cuspal data without scatter. So I would say always have your patient in the open bite position, whether it's the bite tab on the CT scanner or a cotton roll. It'll separate the cusps of the teeth, and it will give you enough information that you can successfully merge these. So the answer is yes, you have to deal with scatter. You can play with the threshold settings on the volumetric rendering until you can get the best balance of removing artifact, but also keeping the data you need, but also having the incisal and cuspal data by taking the CT scan in an open bite. I can maybe think of literally one case where I was worried about it being merged accurately. Otherwise, I pretty much can get it to go every time.
Okay, thank you, Zach. And another question that we had was, which step do you think is the most complicated one in the digital implant workflow?
For me, this is speaking as a periodontist. For me, it's doing the wax ups. It's the restorative design. Now, those of you who are practicing CAD/CAM dentistry, it's going to be the opposite, right? There are steps that are critical. And I've also seen, as an instructor, I've seen how every step of the way can be messed up. But for me, it's the restorative wax up. I find that to be the most difficult, especially with complex multi-unit aesthetic cases. Those are high stakes, and we need a lot of information in order to tie those together. I've shared some of the strategies that we use for accomplishing those. I think, critical steps are emerging, obviously the intraoral models with the CT, but I find that with the experience I have, I don't really have much problem with that. And, there's a learning curve to doing every step of the way, even the 3D printing. Planmeca makes a 3D printer that's pretty much plug and play, which makes it a lot easier, the Creo. But, I think the main thing, the hardest part is jumping in. It's jumping into the whole process and tying everything together. Once you get a couple cases under your belt and you get a feel for the entire workflow, then it's predictable and it's efficient.
Good answer. Thank you, Zach. So I want to thank you all for attending, and especially Zach for giving us this wonderful presentation. Just for all of you to know that we have recorded this webinar, so it will be available later also on our Vimeo and YouTube pages. But it might take a few weeks because we have had so many webinars, so until we get it online. But it will be there. And also as a reminder for all of you, or something that I want to mention, is that now that we have released Romexis 6, it might not yet be available in all the different countries. So, for example, for the United States, the official release date in United States is, I think it's only the 1st of June. So, but it should be soon available all around the world. And also there are some nice offers that we have on our specialist modules, so please do contact your local distributor to ask about those offers. Of all of you who want to upgrade to Romexis 6, and if you want to add to your maybe already existing licenses, for example, this implant planning and implant guide module, so you have a special price for those now for a limited time. But thank you, Zach, again. I won't take any more time. We passed our time by 2 minutes, but I think it was okay because the topic was so interesting. So I hope all of you enjoyed the webinar, and I hope all of you have a great day or evening ahead as well.
Thank you so much, Sala. Yeah, this has been fun.
Thank you, Zach. Bye-bye.
Bye-bye.